Okay, so this is your voiceover lecture for a review of pharmacology. It's going to be a comprehensive review. The final exam is comprehensive. You guys have taken a lot of exams in here and you've had a lot of material, but it's all really important to know. So if you go back in time to some of our first lectures that we did, we went over basic pharmacology knowledge, such as what are the different names for drugs, right? So we know they all have a trade name. Trade name is that big expensive name that they pay a lot of money for when they're developing a new drug. So a trade name would be more like the brand name. It is protected by law with a trademark. Usually you'll see the R with the circle around it. And it's usually, a certain time period. And then it expires. And then once it expires, if they don't make another formulation of it, like if you remember I told you about Ambien, they had the patent or the trade name for Ambien, and then after that was expiring, when it was coming close to it, they changed the formulary from short acting to long acting, and they were able to extend that. So that's, kind of the things that we're going to see with these drugs. Sometimes that trade name will extend. The trade name is protected by law. It is copyrighted per se. It's patented. Generic, remember, many manufacturers can make, so if you have Coumadin, which is the brand, which I told you they don't make anymore, and then you have warfarin, that's the generic name. There's also Jantamin, which is a generic name for that drug, okay, for that Coumadin. So what happens with a generic name, just remember when we're dealing with generics, we're dealing with a name that is listed in the U.S. Pharmacopedia, okay, but many manufacturers make that generic. So it can be a little tricky if a patient goes to a pharmacy and one company made that generic the one month and then they go the next month, the pill looks a little different. It might be the same color, but it looks a little different. It's another manufacturer, and sometimes the binders can be a little different. So we did go over that trade name is protected by law. Your generic is usually going to be listed in a U.S. Pharmacopedia and will have multiple manufacturers. We also went over some pharmacodynamic and pharmacokinetics, right? So we went over things like pharmacodynamics. I always remember it as a D because pharmacodynamics is what the drug does to the body, and where pharmacokinetics is what? Remember, pharmacokinetics is what the body does to the drug. So that is absorption, right? Starts either in the mouth or however it's being administered, intradermal, subdermal, sub-Q, IM, IV, rectal, transdermal, inhalation. There's going to be different ways that it is absorbed. From there, it goes into and gets metabolized by the liver. Remember, PO, by mouth drugs, go through first pass. Remember, first pass. First pass means the liver inspects it. The only way to eliminate first pass is to give it directly into the bloodstream somehow. So it could go dermal, it can go, remember we have optic too, right? Intranasal, sublingual, IM, IV, all that will bypass that first pass. First pass makes that drug be metabolized in the liver first. So you actually, your PO dose, your by mouth dose might be 10 milligrams, but your IV dose might be 1 milligram. Okay, because you need less drug when you're giving it IV, where you need more drug when you're giving it by mouth because of that first pass phenomena that happens in the liver. The next step of your pharmacokinetics is now distribution. How is it being distributed throughout the body, and it's getting around, it's getting delivered, and activating its mechanism of action, which is what the drug does. Okay, what is it doing to the in that area that makes it work? Once it's distributed and utilized in wherever it gets delivered, then it gets brought back and we have to excrete it. Okay, so there's the 4 steps: absorption, absorption, metabolizing, and then distributing and excretion. So that's your pharmacokinetics, what the body is doing to that drug. Remember, we talked about different things that have to do with the key and lock. So if I have a receptor on a cell and I need the drug to make whatever happens naturally in the body to happen, then that drug will bind to that receptor like a lock and a key. And it can do 2 things, right? Actually, 3 things. It can agonize. Remember, agonistic, if something is at an agonist, what is it going to do? It's going to stimulate a body process. It's going to allow that to happen. If it's an antagonist, this is a little different. An antagonist will prevent or block it from happening. So if you remember, beta blockers are also known as beta cell antagonists. Okay. Then you have partial agonist and partial antagonist, which means it just decreases either the reaction or decreases the blockage. Okay. When we talk about things like synergistic, the best way I can say this is if we give 2 drugs, say drug 1 equals 1 and drug 2 equals 1, 1 plus 1 equals 2, but in synergistic reactions, the 2 drugs actually equal greater than that. So they can be 1 plus 1 equals 3. So synergistic means the total effect of those combos is actually greater than the individual drugs. Think of what we went into with adverse effects. Adverse effects are those drugs that we don't want to see. It's an unwanted reaction. Side effect is something I would expect. Adverse is something we don't want that might happen, and we just have to alert the patient of potential adverse effects. Teratogenic means that it is dangerous to a fetus. A contraindication, remember you have relative versus absolute. Relative would mean it should be used with caution, but an absolute contraindication means it's a warning for certain patients that maybe they should be avoiding that medication. I want you to remember those concepts that you learned about different, especially when we were talking about electrophysiological drugs. So one example would be conductivity. What is that? The heart muscle cell can transfer an impulse to another heart muscle cell. So if a drug blocks conductivity, you're going to have decreased conduction, decreased slowed time, lower heart rates, correct? If you increase conductivity, you'll have faster. Automaticity, remember automaticity is the ability of these cells, especially in the heart, to make their own impulse independent of any of the central nervous system. Then there were certain interesting things about our drugs. One of it was they can be a positive or a negative, right? So a positive inotrope, think about that. Inotropy means the length of contraction. So in the heart, if I increase, if it's a positive inotrope, it will increase contractivity. If it's a negative, it will decrease contractility. Dromotrope, if you remember, dromotrope is going to have to do with the rhythm. Okay, dronotrope is going to have to do with the rhythm. Chronotrope is going to have to do with the rate. Okay, chronotrope, remember, is a watch, and we watch the second hand. So you should be very familiar with these terms. Also, that just so you know, there's fill-ins, there's multiple choice, and there's true falses. Now, Now there's going to be certain drugs you must know about. Okay? Norepinephrine, nitroglycerin, amiodarone, also known as cortisone, metoprolol, also known as Lopressor, amlodipine, also known as Norvasc, diltiazem, also known as Cardizem, epinephrine, adenosine, also known as Adenocard, lidocaine, apixaban, which is also known as Eliquis, digitalis, which is also known as digoxin, losartan, atropine, atorvastatin, warfarin, furosemide, also known as Lasix, magnesium, carvedilol, also known as Coreg, clonidine, also known as Catapras. So I would hope that you would have good information on those drugs. These are the most common ones that you guys are going to be encountering in your cardiac patients, in the cath lab, in the EP lab, okay? If you remember, there's different types of drugs we talked about. You should be familiar with those classifications. We know that beta blockers end in a lull. Beta blockers protect the heart after a heart attack, prevent remodeling, slows the heart rate, increases the time it's in diastole, causes increased coronary artery blood flow. So remember, beta blockers end in a lull. Beta 1s, one heart, that's like metoprolol. That's a beta 1 specific drug. If you look at other one like propranolol can actually work on beta 1s and beta 2s, and remember in the beta 2 in the lungs. In the lungs, it causes, when we activate the sympathetic nervous system, you have the sympathetic nervous system and the parasympathetic nervous system. Sympathetic nervous system basically stimulates things. It increases heart rate. It causes pupillary dilation, peripheral vasoconstriction, bronchodilation, decreased gut motility, decreased saliva, decreased urinary output, and GI output. Okay, we're clear. Parasympathetic, known as rest and digest, contrast from fight or flight, that it causes bronchial relaxation. You're not necessarily dilating. It can slow the heart rate, pupils constrict, and peripheral vasodilation. So remember, beta blockers can be either beta 1 specific or beta 2 specific, or they can be non-specific and interfere with both. Got it? Beta antagonists, beta blockers, end in OLOL. We have our calcium channel blockers. I know this gets a little confusing. If we use ones for arrhythmias, such as diltiazem, which is known as Cardizem, IV, we give it usually in rapid AFib to control the rate. It is a non-pene, okay? It's still a calcium channel blocker. Amlodipine is a calcium channel blocker that's a pene, and this is known as Norvasc, which is more likely going to be used for something like blood pressure. It will work on the peripheral vasculature, okay? So we remember with amlodipine, what are side effects? They get, everything's relaxed and dilated. It'll help for chest pain, right? It'll help, calcium channel blockers help with lowering heart rates. Also for hypertension, right? So it dilates. What's going to happen there? You'll get some peripheral edema. They might get cold sensitivity in the winter. If you remember, I did go over a beta blocker, alpha blocker, that's called carvedilol, Coreg. We use these in patients that have congestive heart failure or ejection fractions with reduced ejection fractions under 40. You'll see these patients on it, okay? Carvedilol has both alpha and beta blocking, okay? where we know that the rest of the beta blockers work specifically on the betas. The carvedilol works on alpha and beta. And remember, our cardioselective is going to be active on a beta 1 receptor, and that's an example of metoprolol. Be familiar with your ARTNs, which are ARBs, angiotensin receptor blockers, and your PRILs, which are ACE inhibitors. Remember the difference? Okay, we're going to get to the RAS system. Renin-angiotensin-aldosterone system. So when my blood volume's low, my blood pressure's low, all my senses in my carotid, I have them throughout some of my vessels. I have the sensors located in my kidney. My kidney says, oh my God, are we hemorrhaging to death? Or we just have a low EF or low cardiac output? I'm not getting the blood flow I need to my kidneys. So what's going to happen? The kidney's going to release renin. Renin is going to activate angiotensinogen in the liver. The liver's going to convert the angiotensinogen to angiotensin 1. Angiotensin 1 has to be converted by angiotensin converting enzyme to angiotensin 2. Angiotensin 2 is going to cause peripheral vasoconstriction. It's going to tell the pituitary, the posterior pituitary, to release anti-diuretic hormone, which will cause us to hold on to more fluid instead of peeing it out. It will also activate the adrenal cortex, okay, to release aldosterone. Aldosterone, remember the cortex of the adrenal is salt, sex, and stress. That's aldosterone, cortisol, and your sex hormones. So aldosterone is powerful. It tells the kidney, retain sodium. And if you remember where salt goes, water follows. If it stays in the vessels, we're going to increase blood volume. There's also a secondary effect to the renin-angiotensin system that triggers the adrenal medulla to trigger the sympathetic nervous system to increase heart rate. Okay? Increase blood pressure. Okay, so now that you know that, angiotensin receptor blockers are going to block it at the angiotensin 1 or 2, and it will prevent the conversion into all these things that happen to retain blood volume. Okay, so they are known as our ARTANs, like losartan. Okay, our PRILs, like let's think, which one can I use for the PRIL? Think of Acupril, any of the PRILs, Captopril, any of your PRILs are going to inhibit the ACE enzyme that's released from the lungs that converts angiotensin 1, angiotensin 2. That is meant to be protective so we don't cough all the time. If you block that, they're going to have a dry cough. So if we use a PRIL, they have a complaint of a dry cough. If it's bothersome, then we change to an ARTAN. Remember, so we went over beta, diuretics. We have ones that work in the loop of Henle. They are called your loop diuretics. You'll get a lot of potassium loss with them. An example of that is going to be furosemide. Then you have hydrochlorothiazide. That's over in the proximal in the distal tubule away from the nephron. You will have potassium loss. You will have uric acid retention. Hydrochlorothiazide is not going to pull off as much potassium, but it can, and that's a diuretic called hydrochlorothiazide. It's a thiazide diuretic. We also have ones that are in the near the collecting, but also in the distal, and that's called aldactone, spirolactone. They actually retain potassium. So sometimes somebody will be on a furosemide with aldactone or spirolactone. So they might be on furosemide, which is Lasix, and they might be on that because you want the diuretic effect, but you want to keep the potassium. Don't forget, we need to know our nitros, the nitroglycerin sublingual. There's different ways we administer them. What do they do? Relieve chest pain, can lower blood pressure. What do we use adenosine for? Adenosine is an antiarrhythmic. It's not in any of the categories. But that is what we use for supraventricular tachycardia. It has to be given very, very fast through the IV. Let's think about your antiarrhythmics. Remember, your first class is sodium channel blockers. That's like lidocaine. Lidocaine is an antiarrhythmic that we use in the ACLS protocol. It can be also given as a local anesthetic, but we can use lidocaine to suppress ventricular arrhythmias, especially when they're ischemic. We can also use amiodarone for this, but that is a potassium channel blocker. That's a class 3. And we have to be careful with that drug because it does have a black box warning that says, I have a long half-life and I can be very pulmonary toxic. We can also use amiodarone. It's interesting, use it for atrial and ventricular arrhythmias. So it can be used for atrial fib, and it can also be used for ACLS protocols with VTAC. And then remember, class 2 is beta blockers, and class 4 is your calcium channel blockers. Atropine is an anticholinergic that we use to raise the heart rate in symptomatic bradycardia. Okay, atropine is contraindicated in patients that have glaucoma, but we use it IV for symptomatic bradycardia. Don't forget your blood thinners. Remember, apixaban, diazepam, and riboxaban are all the NOACs. They're blood thinners that work through the coagulation intrinsic extrinsic pathways, but they do not require blood tests. If you recall, warfarin is working on the extrinsic pathway, and you look at the INR. The INR should be between 2 to 3 for people with AFib, 2.5 to 3.5 for those with valves, and 1.8 to 2.2 for those with LVADs. That would be for your warfarin. Your heparin works on the intrinsic pathway, and you would be checking your PTT. Got it? Okay. What can we give for torsades? Torsades, that is a ventricular tachycardia, a form of it. We usually would give magnesium for that. Okay? So what do we know about the aldactone or spirulactones? Those drugs sometimes have side effects. They retain potassium, but sometimes people get gynecomastia with that. They develop breasts, even in men. Remember, you have to know your routes of administration for medications. Please know at least 5 of them. What are the goals in ischemic heart disease? What do we want to do when they come in with ischemia? Reduce the myocardial demand, increase the supply, decrease the workload, right? We want to reduce any workload, and we want to increase our oxygen supply. I want you to understand the indications for ACE inhibitors. Why would we put them on? You know it's on the JNC for hypertension. It's also used for people that have diabetes and heart failure. Remember alpha-1 receptors. Please remember your alpha-1 has to do with the vessels constricting. If I use an alpha-1 blocker, they're going to dilate. The patient stands up, what happens? They get dizzy, they fall down, they get dizzy, they pass out, orthostatic hypotension. But remember, they are really good for patients like tamoxifen is known as Flomax, or terrasosin known as Minipress. Really good for patients that have benign prostate hyperplasia. The next thing is your diuretics. Please know the different classes. I'm talking about loop diuretics, carbonic anhydrase, thiazides, aldosterone antagonist, or potassium sparing. Please know the classes and at least an example. Please know your absolute contraindications to ACE inhibitors, angiotensin receptor blockers. Also give me some example names of class 1 antiarrhythmics, lidocaine, class 2 beta blocker, alol. Class 3 would be potassium channel blockers like amiodarone, codarone. And remember, your beta in the class 4 are your cardizem, your calcium channel blockers, diltiazem, and amlodipine, so your penes and non-penes. Also know where beta 1s work, where beta 2s work. Okay? I think you guys will be fine with this. There's about 50 questions, multiple choice fill in, true, false, things like that. Okay? I think we covered everything. Okay. Good luck, and it was a pleasure having you this year in your class, your classes, and I look forward to the rest. Thanks.